Welcome to the Deep Dive. Today we're taking a close look at magnetic resonance angiography, or MRA.
That's right.
You sent over some really insightful chapters from Rutherford's vascular surgery textbook, specifically on MRI and arteriography. Our goal today is to really pull out the key principles,
Yeah, unpack it.
understand why MRA is so useful in medicine, and maybe see where this tech is headed.
Exactly. We'll be digging into the fundamental science that makes MRI and MRA work, and looking at the different ways we can actually image blood vessels, sometimes with contrast agents, sometimes without.
Right.
We'll also cover, the many ways MRA helps diagnose and manage vascular diseases pretty much all over the body, from the big aorta down to the tiny vessels.
Okay.
And importantly, we'll touch on what we need to be mindful of when using MRA, the limitations, potential risks, and also look at some exciting future stuff, especially when we compare it to CTA, computed tomographic angiography.
Right. For you, our listener, who's keen to get a solid handle on important topics quickly, this deep dive should give you a really clear picture of MRA's role in the vascular world. We're aiming for those aha moments, trying to connect the science to how it's actually used for patients, highlighting the main advantages and, considerations without getting totally bogged down in technical jargon.
That's good.
Okay, let's maybe start by unpacking the basic principles of MRI itself. That's really the foundation for MRA, isn't it?
It absolutely is. At its core, MRI uses a really powerful external magnetic field,
Okay.
along with something called magnetic field gradients and also radiofrequency or RF fields. All these work together to generate signals from the tissues inside your body.
And those signals become the image.
Exactly. Sophisticated computers take those signals and turn them into the detailed images doctors look at.
So this super strong external magnet, what's the first thing it actually does?
Okay, so it causes the protons within your body's tissues, primarily in water molecules, to align. You can kind of picture these protons as tiny spinning magnets.
Right.
Normally, they're all pointing in random directions, but
Yeah.
when you put them in a strong magnetic field, they tend to line up with that field.
Okay.
And the strength of this external field, that determines the specific frequency, the resonance frequency at which these protons will respond to the RF pulses we send in.
And how strong are we talking? The textbook mentioned Tesla units.
Yeah, exactly. Most clinical MRI systems you'll find operate at field strengths of 1.5 or 3 Tesla, that's T. Although, interestingly, the book does note that 7 Tesla systems are now starting to be used clinically, mainly for imaging the head and extremities.
Wow, 7 Tesla. So higher Tesla means more powerful magnet.
Precisely. And there's a trade-off with these different strengths. For instance, 3T systems, they generally have the potential to give you higher resolution images, maybe faster scan times too, which is often a plus.
But there's a downside.
Yeah, the flip side is they also tend to deposit more RF energy into the patient's body. It's something we have to manage carefully.
Okay, so we've got aligned protons thanks to the big magnet. What's the role of those magnetic field gradients you mentioned?
The gradients, they're crucial. They create small, very precisely controlled variations in the magnetic field strength across the area we're imaging,
And why do that?
because it allows the MRI system to figure out where the signals are coming from. It's called spatial encoding. Essentially, the gradients make protons in different locations resonate at slightly different frequencies, telling the machine the signal's origin point.
I see.
And the rapid switching on and off of these gradients, that's actually what produces those characteristic loud knocking or banging sounds you hear during an MRI scan.
Ah, okay. That explains the noise.
Mm-hmm.
So magnet aligns, gradients locate.
Huh.
What about the RF coils?
Right, the RF coils. They act as both a transmitter and a receiver, like an antenna. They transmit radio frequency pulses at that specific resonance frequency of the aligned protons.
Giving them a little nudge, sort of.
Exactly, a little energy nudge. Then, when these excited protons relax back to their aligned state, they emit a tiny signal of their own. And that signal is detected by the same RF coil, or sometimes a different receiver coil.
So send out a specific radio wave, then listen for the echo coming back.
That's a really good analogy, yes. And finally, this detected signal, how does it become a picture? That raw signal goes through a pretty complex mathematical process called a Fourier transform.
Okay.
This transform is what converts all the frequency and timing information embedded in the signal into the spatial information needed to reconstruct the final MR image that we see on the screen.
Fascinating process. Okay, so we've got the basics of how the signal is generated. Now, what about the images themselves? I know people talk about T1 and T2 weighted images, how they differ, and which one is more important for looking at blood vessels with MRA.
Good question. The contrast in MR images, basically how bright or dark different tissues look, depends on two main things: the inherent properties of the tissues themselves and the specific settings, the parameters we use during the scan. T1 weighted and T2 weighted images are kind of the two fundamental types. They highlight different tissue characteristics. For instance, on T2 weighted images, fluids like water or the cerebrospinal fluid around your brain and spinal cord, they tend to appear very bright.
So T2 is good for seeing fluid collections, maybe inflammation?
Often, yes. Now, for MRA, magnetic resonance angiography, which is focused on arteries, and also MRV for veins, we generally rely more on T1 weighted image sequences.
Why T1 for vessels?
Because on T1 weighted images, certain things naturally produce bright signals. This includes fat, methemoglobin, which you find in slightly older blood clots, the effects of blood flow itself, and crucially for contrast-enhanced MRA, the MRI contrast agents we inject.
Ah, so the contrast makes the blood bright on T1 images.
Exactly. So as a rule of thumb, if something looks bright on a standard T1 weighted image, it's probably going to look bright on an MRE image too, especially if contrast is used.
Got it. MRA uses T1 weighting to make vessels pop out. Now, the outline mentions pulse sequences. Sounds technical. What are they?
A pulse sequence is basically the recipe, the set of instructions we feed into the MRI machine for a specific scan.
Okay.
It defines the exact timing and combination of those RF pulses and the magnetic field gradients we talked about. Changing the sequence changes the type of image we get, its contrast, and how sensitive it is to different things.
And the book mentioned spin echo and gradient echo.
That's right. Those are two main families of pulse sequences. Spin echo sequences often rely primarily on RF pulses to create contrast, and they're commonly used for generating those standard T1 and T2 weighted images for general anatomy and pathology.
Okay.
Gradient echo sequences, on the other hand, use both RF pulses and gradient switching to generate the signal. They tend to be faster.
Faster is good for MRA.
Often, yes. Gradient echo sequences are particularly well suited for MRA because they're more sensitive to blood flow effects and they work really well with the contrast agents. So much of MRA is based on gradient echo.
And then there are parameters like TE and TR, echo time and repetition time. What do they control?
TE and TR, very important. TE, the echo time, is basically the time between sending in the RF pulse and listening for the signal echo coming back.
Okay.
TR, the repetition time, is the time between repeating that whole process, sending in the next RF pulse.
And adjusting those changes the image.
Absolutely. They are key determinants of image contrast, what's bright, what's dark. They also massively influence how long the scan takes. For example, T2 weighted images typically use longer TE and TR values, making them slower.
But for MRA, you said speed is key.
Right. To capture the dynamics of blood flow, especially with contrast, you need speed. So MRA typically uses fast T1 weighted gradient echo sequences that have very short TE and TR values. Get the snapshot quickly.
Makes sense to capture the image while the contrast-filled blood is actually flowing through. The outline also brings up field of view, FOV, and image matrix. How do they affect the final picture?
Good points. The FOV field of view just defines the physical size of the area you're imaging. Maybe 30 by 40 centimeters across the abdomen, for example, plus the slice thickness. The image matrix determines how many individual picture elements or pixels are packed into that FOV. Think of it like the resolution on your TV screen.
More pixels means sharper image.
Generally, yes. A higher matrix size means more pixels in the same area, which translates to higher spatial resolution. That lets us see finer details in the blood vessels.
And an MRA is usually 3D.
Yes, most modern MRA is done using 3D sequences. So the FOV is a volume, and the matrix defines the size of each tiny 3D cube called a voxel. This 3D data gives us a lot of flexibility later.
Okay, great foundation. Now let's get to the main event. MR angiography and venography itself, actually seeing those blood vessels. The outline splits this into non-contrast and contrast-enhanced techniques. Let's start with non-contrast MRA. It mentioned a renewed interest. Why is that?
That's a really important point. Historically, non-contrast MRA techniques like time of flight or TOF, they were maybe seen as a bit less reliable than contrast-enhanced MRA, which usually gave, well, arguably better images.
But something changed.
Yes. The discovery of a link between gadolinium-based contrast agents, GBCAs, and a serious condition called nephrogenic systemic fibrosis, or NSF, particularly in patients with poor kidney function.
Okay.
That discovery led to a major resurgence of interest in non-contrast techniques. It's a way to potentially avoid that risk altogether in vulnerable patients. These methods let us see blood flow without any injection, which is a huge deal for people with kidney problems.
NSF sounds serious.
Ah.
We definitely need to circle back to that when we discuss risks. So how does this non-contrast TOF technique actually work? How does it make blood vessels visible without dye?
It's quite clever, actually. TOF angiography uses a fast T1 weighted sequence. Now imagine you're repeatedly sending RF pulses into a slice of tissue.
Okay.
The stationary tissue within that slice keeps getting hit by these pulses, and its signal becomes saturated, meaning it gets weaker and looks dark on the image. But the blood flowing into that slice from outside hasn't seen those repeated pulses yet. Its protons are fully magnetized. So when that fresh blood flows in, it gives off a much brighter signal compared to the suppressed background tissue.
So flow, in effect, makes the blood bright.
Exactly. Flowing blood appears bright against a dark background of static tissues. It's called flow-related enhancement.
Neat. And I see it mentions using saturation pulses to selectively suppress arterial or venous signals. How do you do that?
Right. Another clever trick. We can apply an extra RF pulse, a saturation pulse, either just upstream or just downstream from the slice we're imaging.
Like tagging the blood.
Sort of. For example, if we apply a saturation band below an imaging slice in the abdomen, it zaps the signal from venous blood flowing upwards from the legs before it enters the slice.
Okay.
That way, the arterial blood flowing downwards into the slice remains bright, making the arteries stand out more clearly. Flip the saturation band to be above the slice, and you'd suppress the arterial signal and highlight the venous flow coming up.
So you can choose whether to see arteries or veins better just by placing these saturation bands.
Precisely. You can selectively enhance one or the other.
The chapter lists other non-contrast methods too, SSFP, ASL, FBI, QISS. Are any of these particularly noteworthy?
Yeah, there's a whole alphabet soup of techniques. SSFP, steady state free precession, is interesting because it can be very fast and provides bright signal from blood, good for both large and small vessels without contrast. ASL, arterial spin labeling, actually uses magnetically tagged blood water itself as an internal tracer to map blood flow or perfusion.
Wow.
Others, like FBI, FSD, QISS, they all have specific advantages and disadvantages, maybe related to flow speed or sensitivity to magnetic field uniformity. But honestly, in day-to-day practice, TOF and contrast-enhanced MRA are still the most commonly used workhorses. QISS, for instance, can be really fast for speedy flow, but needs a very stable magnetic field.
Okay. Really exciting that these non-contrast options are improving, especially given the kidney concerns. Now, let's flip to the other side. Contrast-enhanced MRA. This sounds like it's still a cornerstone technique.
Yeah.
How does it work?
It definitely is. Contrast-enhanced MRA, or CE-MRA, uses those gadolinium-based contrast agents, the GBCAs.
Okay.
When these are injected into your bloodstream, they have a specific property. They dramatically shorten the T1 relaxation time of the water molecules immediately around them.
T1 again.
Yep. And because, as we said, MRA typically uses T1-weighted sequences.
That shortening effect makes the signal brighter.
Exactly. The blood within the vessels where the GBCA is concentrated appears much, much brighter on the images than the surrounding tissues.
So just to be clear, we're not actually imaging the gadolinium atoms themselves.
That's a really crucial point. No, MRI detects the effect the contrast agent has on the surrounding water protons, not the agent itself.
And what's the significance of that?
It means even a very tiny amount of MR contrast can have a big effect, because its influence is amplified across many, many water molecules nearby.
So you don't need as much contrast compared to other types of imaging.
Generally, yes. That's one reason why the volume of MR contrast used in MRA is often significantly less than the volume of iodinated contrast you'd use for a CT angiogram or a traditional catheter angiogram.
That's a great insight. And the chapter mentioned other potential advantages of GBCAs over the iodinated contrast used in CT.
Right. Besides the lower volume, there's generally a lower risk of nephrotoxicity, kidney damage. Although, as we just discussed, that comes with a big asterisk about NSF in patients with severe kidney disease.
Right, the NSF risk.
But compared to iodinated contrast, GBCAs also tend to have a lower incidence of allergic-type reactions or other immediate adverse effects.
So potentially safer from an allergy perspective, too. Now, imaging large areas like the whole aorta or all the leg arteries, the outline mentions step table and continuous table MRA. What are these approaches?
Yeah, when you need to image a long stretch of vessels, like from the belly down to the feet, doing it all in one single acquisition can be tricky. You might compromise on image quality or resolution, or maybe the timing of the contrast isn't perfect everywhere.
So you break it up.
Exactly. Step table MRA does just that. It images different anatomical segments sequentially. The MRI table physically moves the patient between these stations.
Like taking separate pictures of the thighs, then the calves, then the feet.
Precisely. So maybe station 1 is the abdomen pelvis, station 2 is the thighs, station 3 the calves, and so on. Each station gets positioned optimally in the magnet center.
And you can optimize settings for each part.
Yes, you can use different coils, different field of view settings, resolution, orientation, tailor it for the anatomy in that specific region. Usually we go from top to bottom, proximal to distal, but sometimes if the main problem is suspected lower down, we might do a reverse step table.
Any drawbacks to step?
Well, it can take a bit longer overall, and sometimes by the time you get to the lower stations, the contrast might have started washing out of the arteries and showing up in the veins, which can make interpretation a bit trickier. That's called venous contamination.
Okay. And then there's continuous moving table MRA. How is that different?
Continuous moving table MRA is more like how a helical CT scanner works. The patient table moves smoothly and continuously through the scanner while the MRI data is being acquired.
No stopping.
Right. This can help minimize motion artifacts, and it also allows for a technique called bolus chasing.
Bolus chasing. Sounds like you're following the contrast.
That's exactly what it is. You try to synchronize the speed of the table movement with the speed that the contrast agent is traveling down the arteries.
So you're always imaging where the contrast is brightest in the arteries.
That's the goal. It helps maintain good arterial enhancement throughout the whole run and can really reduce that venous contamination problem we mentioned.
That sounds like a neat way to get long coverage with good arterial signal.
Okay, so once we've got all this 3D data, especially from contrast-enhanced MRA, how do we actually look at it? The outline mentioned 3D image processing.
Right, because CE-MRA usually gives us these rich 3D data sets. We have a lot of flexibility in visualizing the vessels. Multiplanar reformatting, or MPR, is fundamental.
What's that?
It lets us slice through the 3D volume electronically to create 2D images in any plane we want: standard axial, cross-section, sagittal side view, coronal, front view, or even angled oblique views.
So you're not stuck with just the original scan orientation.
Not at all. Then there's maximum intensity projection, or MIP. This is super common in MRA.
How does MIP work?
The algorithm essentially looks through the 3D data from a particular viewpoint, and along each line of sight, it only displays the brightest voxel, the brightest little coud of data.
And since the contrast-filled blood is brightest.
The MIP image effectively creates a kind of roadmap of the brightest structures, which are usually the blood vessels.
Like an X-ray projection, but based on brightness. Kind of, yeah, based on MR signal intensity. Another powerful technique is volume rendering, or VR. This often gives a more, 3D-looking, shaded representation of the vessels. Sometimes it's even better than MIP for understanding complex anatomy.
Okay, great processing tools.
Yeah.
Now, what about the hardware and software needed to do top-notch MRA? What makes a good MRA setup?
Yeah, for optimal MRA, you really benefit from having higher field strength systems, ideally 1.5 or even better, 3 Tesla.
Okay.
These should be equipped with fast, strong magnetic field gradients, multi-channel RF receivers and coils, and importantly, powerful computers for image reconstruction.
Why are all those components important?
Well, stronger magnets and better gradients generally mean potentially shorter scan times, higher spatial resolution, seeing finer details, and a better signal-to-noise ratio, which means clearer images. The faster computers just handle the complex data processing more quickly. The jump to 3T, for example, often gives a noticeable boost in image quality for MRA in many parts of the body.
You mentioned trade-offs with 3T earlier, though, the RF energy deposition.
Yes, that's the main one. At 3T, the amount of RF energy deposited in the patient measured as the specific absorption rate, or SAR, is 4 times higher than at 1.5T.
4 times, wow.
Yeah. There are strict safety limits on SAR, and you hit those limits more easily at 3T. While it's not usually a showstopper for standard contrast MRA, it can be a factor for some non-contrast techniques or things like cardiac MRI. Plus, 3T systems cost more and can sometimes be more prone to certain types of image artifacts, so it's a balance.
Better signal versus potential heat and artifact issues. Got it. What about those dedicated RF coils?
Oh, absolutely crucial. Coils are the antennas that transmit and receive the RF signals. Using coils specifically designed to fit snugly around the body part you're imaging makes a huge difference in signal quality.
It's like different shapes for different parts.
Exactly. You'll have a neurovascular coil for the head and neck, maybe a long wraparound peripheral angiography coil for the legs, flexible phased array coils for the torso.
Phased array?
Yeah, multiple small coil elements working together. For really small vessels, like in the hands or feet, we might use small, high-resolution local coils. Sometimes even a head coil can work well.
And these multi-channel coils enable something called parallel imaging. How does that speed things up?
Right. Parallel imaging is a collection of smart techniques that use the fact that we're receiving signals simultaneously from multiple coil elements.
Okay.
By analyzing the unique spatial information from each coil, the system can essentially reconstruct the image using less raw data, which means acquiring the data faster.
Is there a catch?
The main trade-off is usually a slight hit in the signal-to-noise ratio. So it works best when you have plenty of signal to start with, which is often the case in contrast-enhanced MRA. Most modern CE MRA scans now routinely use parallel imaging.
Cool. The outline also mentioned compressed sensing. Sounds very advanced.
It is pretty cutting edge. Compressed sensing is a different mathematical approach, again allowing us to reconstruct high-quality images from significantly undersampled data, meaning we collect much less data than traditional methods would require.
Which means even faster scans.
Potentially dramatically faster, yes. This is super useful in tricky situations like scanning kids who can't hold still for long or needing really short breath holds for adults. Compressed sensing is definitely a technology to watch in MRA.
Okay, shifting gears slightly, what about the practical stuff? Injecting contrast, monitoring the patient.
Right. For contrast MRA, you need an MR-compatible power injector, usually a dual-chamber one.
Why dual chamber?
So you can inject the contrast agent rapidly, followed immediately by a saline flush from the second chamber. The saline pushes the contrast bolus through the vessels efficiently and can actually help reduce the total contrast dose needed.
Smart. And patient monitoring.
Absolutely vital, especially for sicker patients or those needing sedation. You need MR-compatible monitors for ECG, oxygen levels, etc. Interestingly, there are even special MR-compatible blood pressure cuffs.
What are they used for?
Sometimes, particularly in leg MRA, inflating a cuff on the thigh briefly can slow down the venous return from the lower leg.
Ah, reducing that venous contamination again.
Exactly. It helps keep the veins darker while the arteries are bright, improving visualization. A neat little trick.
Definitely.
Huh.
And lastly, after the scan, what about the software for looking at the images?
A good post-processing workstation is non-negotiable. It absolutely has to have those MPR, MIP, and VR capabilities we talked about.
Reformatting and 3D views.
Yes, and often additional software tools are really helpful. Things like curved planar reformatting, which lets you straighten out a curvy vessel to see it along its length.
Oh, cool.
Automated vessel tracking to measure diameters, maybe tools for subtracting bone, though that's more common in CT. These advanced analysis tools can really aid interpretation, especially for complex cases.
All right, fantastic overview of the tech side. Now let's get into the clinical applications. Where does MRA really shine in day-to-day medicine? Let's start up top with the aorta.
Okay, aortic vascular disease. Contrast-enhanced 3D MRA is a powerhouse here. It's great for evaluating the aortic arch. Some even argue it might be better than other methods for certain things there.
Like what?
Diagnosing aortic dissection, which is a tear in the aortic wall. Assessing aortic aneurysms, those dangerous bulges. It's also key for monitoring patients with conditions like Marfan syndrome that weaken the aorta.
And for treatments.
Absolutely. Crucial for planning stent graft placement for aneurysms and then following up afterwards to check for problems like endoleaks, especially with the newer nitinol stents.
Okay. Moving down a bit, what about the carotid arteries in the neck? Big role in stroke prevention, right?
Huge role. MRA is very sensitive for picking up atherosclerosis plaque buildup in the carotids. It's particularly good at identifying significant narrowing or stenosis, say in that critical 70% to 99% range.
So it helps decide who needs surgery or stenting.
Exactly. Because it's pretty accurate in grading the stenosis, many centers use MRA as a key tool for planning those carotid revascularization procedures to prevent strokes.
Makes sense. Now, down to the limbs, peripheral vascular disease, or PVD.
Yeah, MRA has really become a standard non-invasive workup tool for PVD. It's excellent for preoperative assessment.
How so?
It shows the inflow vessels, identifies where the blockages or narrowings are located. Compared to the old gold standard, catheter angiography, DSA, MRA stacks up really well, high sensitivity and specificity for significant disease.
Any advantages over DSA?
Well, it's non-invasive, obviously. Plus, MRA can sometimes visualize the smaller runoff vessels down in the calf and foot even better than DSA, which is crucial for planning bypass surgery. And it's generally seen as more cost-effective.
And those step table techniques help with the feet.
Yes, things like step table or continuous table MRA have really improved visualization of those distal vessels. MRA is also great after interventions like bypass grafts or stents to check if they're still open, look for new narrowings, or spot complications like pseudoaneurysms. There are even studies showing MRA can sometimes see more vessels in the foot than DSA can.
Impressive.
Mm.
Okay, how about the kidneys? Renal vascular disease?
3D gadolinium enhanced MRA is pretty much the clinical standard now for looking for renal artery stenosis narrowing of the kidney arteries, which can cause high blood pressure.
Mainly atherosclerosis.
That's the most common cause, yeah, especially near the artery's origin. But MRA is also good for other things like fibromuscular dysplasia, FMD, which often affects younger people, renal artery aneurysms, and spotting accessory renal arteries.
Accessory arteries. Why is that important?
It's super important if someone is being evaluated as a living kidney donor. The surgeon needs to know exactly how many arteries supply the kidney they're planning to take. MRA helps avoid surprises.
And it reduces the need for invasive angiograms.
Often, yes. Good MRA can provide the roadmap for treatment, reducing contrast exposure and procedure time.
Okay, now the gut mesenteric vascular disease.
Yep.
Affecting blood supply to the intestines.
Right. MRA is often used when doctors suspect chronic mesenteric ischemia, sometimes called intestinal angina, usually caused by narrowing of the gut arteries. It's pretty accurate for disease in the main superior mesenteric artery.
Any other mesenteric uses?
Yeah, it can help diagnose trickier things like median arcuate ligament syndrome, where a ligament squashes the celiac artery. MRA can sometimes show this compression happening dynamically by imaging during breathing expiration versus inspiration.
Wow, what about the veins in the gut?
Ah, yes, mesenteric venous thrombosis clots in the gut veins. MR venography, or MRV, is excellent for this. It might even be better than catheter angiography sometimes because MRI is so sensitive to the signal changes caused by clot.
So MRV is strong for veins.
Yeah.
How else is it used for venous problems?
MRV is really useful for looking at the big central veins, like the superior vena cava near the heart, and also the deep veins in the pelvis and legs.
For DVT, deep vein thrombosis.
Exactly. It's highly sensitive for thrombus in the central veins. For the legs and pelvis, we often use that non-contrast 2D time-of-flight technique. Interestingly, MRV can sometimes find pelvic DVT that might be missed by ultrasound, especially if a patient has had a pulmonary embolism, but their leg ultrasound is negative.
So it can find the source.
Potentially, yes. Both the non-contrast TOF and post-contrast T1 images can be helpful for diagnosing DVT pretty much anywhere.
The versatility is just amazing. Arteries, veins, all over the body. The outline mentioned other applications too. Any quick examples?
Sure. It's used for thoracic outlet syndrome, often with special arm positions, essential in kidney transplant evaluation both before and after surgery to check the vessel connections.
Okay.
Good for large vessel vasculitis like Takayasu arteritis, can detect pulmonary arteriovenous malformations quite well. And a newer use is mapping out tiny perforator arteries in the abdominal wall for certain types of breast reconstruction surgery called DIEP flaps.
Incredible range. But, like any tool, MRA must have its limitations and risks. Let's talk about those. Scan artifacts were mentioned. What kind of things can go wrong with the images?
Yeah, artifacts are definitely something radiologists watch out for. One example. In the chest, the techniques used to suppress the bright signal from fat.
Fat saturation.
Right. Sometimes, if a blood vessel is right next to the lung, that fat suppression can accidentally suppress the vessel signal too, making it look falsely narrowed or blocked.
Okay, tricky.
Another one. Sometimes right when the contrast first hits, especially near the heart or in the subclavian artery, a very high concentration can cause a signal dropout, a dark spot, that mimics a stenosis. This is a susceptibility artifact. Usually, imaging again quickly as the contrast dilutes fixes it.
What about metal?
Big issue. Metal implants, stents, clips, joint replacements cause significant signal voids and distortions. There are special sequences like Emavir or CMAC designed to reduce these artifacts, but they don't eliminate them completely. Metal can really obscure nearby vessels.
And one more. Something about old blood clots?
Right. Blood clots that are a few days to a couple of weeks old contain methemoglobin. Methemoglobin happens to be naturally bright on T1-weighted images.
So it looks like contrast.
Exactly. It can mimic contrast enhancement within a vessel, potentially hiding a real blockage or making you think there's flow where there isn't. That's why getting pre-contrast T1 images first is often important to see if anything is already bright before the injection.
So definitely pitfalls to be aware of during interpretation. Now, what about contraindications? situations where MRA might be risky. We touched on renal disease and NSF earlier. Can you expand on that?
Yes, NSF, nephrogenic systemic fibrosis. This is the big one related to contrast. It's a debilitating, sometimes fatal, disease-causing skin thickening, joint contractures, and potentially organ fibrosis.
And it's linked to gadolinium.
Strongly linked, yes, specifically in patients with severe kidney impairment like those on dialysis or with very low kidney function, low GFR. The thinking is that if the kidneys can't clear the gadolinium quickly, it stays in the body longer and the gadolinium ion might detach from its carrier molecule and trigger this fibrotic process.
Are all gadolinium agents the same risk?
No. There are different chemical structures. The macrocyclic agents seem to hold on to the gadolinium much more tightly than the older linear agents.
So macrocyclics are safer.
They have a significantly lower association with NSF. Current guidelines strongly recommend using only macrocyclic agents in patients with severe kidney disease, and only if absolutely necessary at the lowest effective dose. And for dialysis patients, dialysis soon after the scan is often recommended to help remove the agent.
So for these patients, non-contrast MRA or maybe CTA is often preferred.
Absolutely. Avoiding gadolinium altogether is the safest bet if kidney function is very poor and a non-contrast alternative is feasible.
Okay, crucial point. What about pacemakers and other implanted devices? Still a strict no-go for MRI.
It used to be, pretty much. But things have changed quite a bit. There are now many MEMR conditional pacemakers and defibrillators, ICDs, specifically designed and tested to be safe under defined MRI conditions.
So some people can get scans now.
Yes. And even for some older non-conditional devices, specialized centers have developed strict protocols to scan patients safely if there's a compelling clinical need and no good alternative.
What are the risks with older devices?
The strong magnetic fields could, pull on the device, heat up the leads, or interfere with its programming, potentially causing it to malfunction, pace incorrectly, or even deliver inappropriate shocks. The biggest fear is the device shutting down in a pacemaker-dependent patient.
So scanning non-conditional devices is complex.
Very. It involves device checks before and after, often reprogramming, continuous monitoring, having cardiology staff present. It's a big undertaking. So, honestly, for routine vascular imaging in a patient with a non-conditional device, CTA is almost always preferred if possible because it avoids all these MRI-related issues. But the rise of MR conditional devices is definitely making MRA more accessible.
Good to know. What about things like vascular stents, IVC filters, or coils used to block vessels? Are they a problem?
Generally less of a problem from a safety perspective. Most modern stents, filters, and coils are made from non-ferromagnetic or weakly ferromagnetic materials like nitinol or certain stainless steels.
So they don't get pulled by the magnet.
Not significantly, no. They're usually rated MEMR safe or MEMR conditional. There was an older stainless steel aortic stent graft that was initially an issue, but even that's now conditional up to 3T after it's had time to embed. While manufacturers sometimes suggest waiting a few weeks after placement for tissue to grow around the device, truly non-ferromagnetic devices can often be scanned immediately if needed.
But they can still cause artifacts.
Oh, absolutely. Even if safe, metallic implants can cause major signal voids, black holes, and distortions on the images. Stainless steel and platinum are often worse than nitinol. These artifacts can totally obscure the vessel inside the stent or downstream from it, making it impossible to reliably assess for blockage or narrowing. So safety is one thing, image quality is another.
Right, a key distinction.
Right.
Okay, looking ahead now. What exciting future advances are coming down the pike for MRA?
Lots of cool stuff happening. Those continuous moving table techniques are getting smarter, better synchronization with contrast, reducing artifacts further, and then there's time-resolved MRA.
What's that again?
It's acquiring multiple rapid snapshots as the contrast flows through. This gives you dynamic information. You can see the direction of flow, watch arteries fill, then veins, assess how quickly things wash out. Like a movie of the contrast passage.
But you sacrifice resolution.
Traditionally, yes, there was a trade-off between temporal resolution speed and spatial resolution detail. But techniques are constantly improving to get better detail faster.
Very useful for understanding flow dynamics. What about new contrast agents?
Yeah, that's a big area. The standard GBCAs we use distribute pretty quickly out of the blood vessels into the surrounding tissues.
Okay.
So the time window for perfect arterial imaging can be short. There's a lot of interest in blood pool contrast agents, BPCAs.
BPOOL, they stay in the blood longer.
Exactly. They're designed to remain intravascular for much longer periods. This could allow for longer, higher resolution scans, maybe getting both arterial and venous phases clearly in a steady state.
Any examples?
One was Godofus facet, which binds to albumin in the blood. Another class is based on ultra-small iron oxide particles, USPIOs. These have the added potential benefit of being safer in kidney failure patients and might also help image inflammation. Ferromoxitol is an iron supplement that's also a USPIO and has been used off-label for MRA in renal patients.
Interesting. Staying in the blood longer sounds very useful. What about directly imaging blood flow, not just the vessel structure?
Right, beyond just seeing if a vessel is open or closed, phase contrast MRI can actually measure blood flow velocity. 2D versions are used routinely in cardiac MRI.
And in 3D.
That's the Frontier 4D flow MRI. It measures velocity in all 3 directions, evolving over the cardiac cycle. Imagine getting detailed 3D flow maps showing swirls and jets inside an aneurysm.
Wow. Clinically useful yet?
It's getting there. The analysis is complex, and it's still mostly a research tool, but the potential to understand hemodynamics non-invasively is huge.
And the holy grail plaque imaging. Can MRA see inside the vessel wall itself?
Yes, this is another major strength of MRI. Its excellent soft tissue contrast allows it to potentially distinguish different components within an atherosclerotic plaque. The fatty lipid core, the fibrous cap covering it, areas of bleeding within the plaque, even calcification, though CT is better for calcium.
Using contrast for this too.
Both non-contrast techniques and specialized contrast methods are being explored. Some contrast agents might target inflammation, macrophases, or new vessel growth, neovascularity within the plaque, potentially indicating higher risk, unstable plaques. USPIOs and maybe gedofuscexit have shown promise here. And molecular imaging agents designed to stick only to specific plaque components are in development.
So maybe one day predicting plaque rupture non-invasively.
That's the long-term goal. And interestingly, some studies suggest MR angiography is getting pretty close to CT angiography in accurately assessing coronary artery stenosis too.
Amazing potential. Okay, as we wrap up, let's briefly revisit that comparison. MRA versus CTA. They're often the main choices, right? Key differences.
They are. Big difference is speed. CTA is generally much faster. Whole aorta in seconds. Peripheral runoff under 10 seconds sometimes.
Wow.
MRA takes longer, often 30 minutes or more on the table. CTA resolution is excellent and pretty independent of scan time, but timing the contrast bolus just right can be trickier in CTA, and repeat scans mean more radiation.
MRA has no radiation, right?
Correct. Big advantage for MRA, especially for younger patients or those needing many follow-up scans. CTA uses X-rays.
What about dynamic info?
MRA, especially time-resolved MRA, can give you that flow physiology information, though maybe at lower resolution. CTA is usually a static snapshot, although the newest super-wide CT scanners might allow some dynamic imaging, but likely with higher radiation.
How do they handle calcium and metal?
MRI doesn't see calcium well, which can be a limitation sometimes, but it's also less bothered by artifacts from heavy calcium than CTA is. Both struggle with metal artifacts from stents or implants, though the artifacts look different. CTA is usually preferred for patients with non-MR conditional pacemakers.
And contrast risks.
We covered the hemorrhagodelinium NSF issue in kidney disease. CTA uses iodinated contrast, which has a higher rate of general allergic reactions and its own risk of kidney injury. Contrast-induced nephropathy, especially in patients who are dehydrated or have borderline kidney function.
Practicalities. Ease of use.
CTA scans are much quicker, less time in the machine, fewer breath holds usually. So often more convenient, maybe better for claustrophobic patients or those who can't lie still. MRI setup takes longer, more sequences.
But interpretation.
Often, MR angiograms can be a bit easier to read because the background tissues are naturally suppressed, making the bright vessels stand out clearly. A 3D MRA might have fewer raw images to scroll through than a comparable CTA.
So no single winner.
Not really. The choice often boils down to the specific clinical question, the patient's condition, especially kidney function, implants, what equipment and expertise are available locally, and honestly, the comfort level of the referring doctor and the radiologist with each technique. They're often complementary tools.
Okay, let's try to synthesize this. Key takeaways from our deep dive into MRA. We've gone through the underlying physics, the different ways it's done with and without contrast, looked at its huge range of uses from aorta to foot, arteries, and veins. And importantly, discuss the artifacts, risks like NSF, and contraindications like certain pacemakers. So for you, the listener, you should now have a much better feel for how MRA gives us these incredible views inside blood vessels, its specific strengths, and also where it fits alongside other tools like CTA.
Yeah, and what really stands out is how dynamic this field is. Thinking about those rapid advances, particularly in non-contrast MRA and maybe those new blood pool agents, it really makes you wonder, doesn't it?
Wonder what?
Well, here's something for you to think about. How might MRA's role change in the next, say, 5 or 10 years, especially for screening or initial diagnosis? Could we see a real shift away from needing gadolinium for many patients as these non-contrast methods get even better and more widespread?
That is a really interesting thought to leave with. The pace of innovation is certainly remarkable. If you, our listener, found this interesting and maybe want us to dive deeper into MRA for specific conditions, say just carotid imaging or just peripheral disease, or perhaps explore that MRA versus CTA comparison in more detail for certain scenarios, let us know. That could definitely be fertile ground for a future deep dive.
Absolutely.
Thanks for joining us on this deep dive into magnetic resonance angiography.